As you know, in day-to-day clinical practice, renal function is estimated by formulas. Some years ago, some of these formulas are based on creatinine, and some of them based on cystatin C, or the combination of both serum markers. Unfortunately, formulas, the estimated GFR is unreliable. The error of formulas has three major characteristics. The error is frequent, the error is wide, and the error is random. The error of formulas is very frequent. About 60 to 80% of the estimations have an error plus minus 30% of real GFR. This means that for a patient with measured GFR or real GFR of 60 milliliters per minute, formulas may estimate GFR ranging from 42 to 70 to 78 milliliters per minute. This error is unacceptable, and this error has been observed in many clinical situations, such as renal transplantation, chronic kidney disease, diabetics, polycystic kidney disease, etc. Also, the magnitude of the error is relevant. This figure shows a group of patients with a real GFR of 30 milliliters per minute and estimated GFR by 9 formulas based on creatinine and or cystatin C. As you can see, the estimations of GFR may range from 20 milliliters per minute to about 60 milliliters per minute, when real GFR is 30. Diabetic patients with the real GFR of 60 milliliters per minute and estimated GFR by CKD-EP formulas based on creatinine or cystatin C. And as you can see, for two different patients with real GFR of 60 milliliters per minute, the same formula provided the opposite results, either underestimating or overestimating. As you can imagine, the error of formulas has consequences. One of them is the incorrect evaluation of the degree of renal dysfunction. About 30% of the patients are incorrectly classified in CKD stages, and estimated GFR decline is either faster or slower than real GFR decline. Now let me show you some practical example of the error of formulas in clinical practice. In this study, we evaluated the error of formulas in CKD staging. In another study, we evaluate the impact of the error of formulas in the selection of living kidney donors, and we found that about in yellow, that was minus 6.3 milliliters per minute per year, and estimated GFR decline by CKDFB formulas. And as you can observe, estimated GFR decline may range from stability to accelerated GFR decline of minus 16 or 17 milliliters per minute per year, when real GFR decline is minus 6.3. So, under the scientific evidence, we can say that formulas are unreliable, and we wonder what to do to solve this situation. In clinical research, we can measure GFR or renal function by gold standard methods, such as inulin clearance, radioactive markers, or iothalamate or ioexol. However, these gold standard methods have limitations. The techniques are cumbersome and time-consuming, and using liquid samples, the management of the pre-analytical phase is complicated because we have to centrifuge, aliquot, store in freezer, thaw, and re-aliquot the samples for analysis. This scheme represents the general view of the plasma clearance of ioexol. After the injection of the marker, we have to wait 2 hours for the distribution of the markers, and then we collect between the 5 or 7 samples during 4 or 8 hours. So, in this point, nephrology or clinical medicine stands as a crossroads. On the one hand, we have formulas that are simple but unreliable, and on the other hand, we have gold standard methods that are reliable but unpractical. So again, we wonder what to do. We would have three possibilities. The first one would be to create a new equation, but honestly, if the last 60 formulas fail it's far probably that the new one succeed. Another possibility is to use a gold standard method, but as previously described, they are cumbersome and time-consuming and very difficult to be implemented in clinical practice. And the final possibility, that was our choice at the Renal Function Laboratory, led by Dr. Esteban Porrini, was to simplify a gold standard method. So we simplify the plasma clearance of ioexol. And the question here is how to simplify the plasma clearance of ioexol. We have 2 possibilities. The use of a single sampling protocol, like Jacobson did almost 30 years ago, and to use a dry blood spot technique. The Jacobson, the use of a single point measurement using the Jacobson formula is an unreliable approach, like Flavio Gaspari demonstrated in almost 700 patients, because 25% of almost 25% of the cases had an error higher than 40% with respect to the real GFR. So this performance is similar to any equations based on creatinine or cystatin C. And at the Renal Function Laboratory, we observe similar results in almost 3,000 patients. So we decided to simplify the plasma clearance of ioexol using dry blood spot testing. And why DBS and why ioxol? Because ioxol is an ideal marker for DBS. The molecule is very stable at room temperature. That facilitates very much the pre-analytical phase and the analytical phase also as well. And the molecule is also very easy to be extracted from filter paper. Regarding DBS method, we have two choices. And the non-volumetric approach, like Nicolescu tested in 2006, and volumetric approach that was our choice in 2017. This photograph represents the main characteristic of the non-volumetric method. After finger pricking, the whole volume of the drop of blood is placed directly on filter paper, and obviously the volume of this spot is always variable. Then partial spots are punched out. Partial spots are punched out from the filter paper for analysis, but as you can observe, some blood remains on filter paper and is not analyzed. This is the reason why this method is named as partial spot method. Opposite to the non-volumetric method, is similar that we have to apply a finger pricking, but in this case we use a capillary pipette to collect always the same volume of blood, that is 10 microliters, and then this fixed volume of blood is again placed on filter paper, and then will be analyzed. This is the capillary pipette we use, and again this is the key point. It contains a fixed volume of 10 microliters. So we are always analyzing the same amount of blood and the same amount of ioxol, of course. Then for the volumetric method, we punch out the whole spot method, and opposite to the non-volumetric, you can see here that no blood remains on filter paper. This is the reason why these methods are named as whole spot method. In 2017, we published this study where we demonstrated that volumetric method outperformed the non-volumetric method. We use a statistic of agreement to compare the performance of these two test methods with the reference, that is plasma analysis, and the volumetric method gave a TDA of 9%, and the non-volumetric 26%. To well understand the low performance of the non-volumetric method, it is important to acknowledge the big influence of the hematocrit in DBS analysis. So the higher the hematocrit, the lower diffusion of blood through filter paper, and vice versa. Then the non-volumetric method, the error of the non-volumetric method is that assumes that the volume in the partial spot that are punched out for analysis is the same because the diameter of the spots is also the same. But it is incorrect because of the differential diffusion of blood on filter paper according to the level of the hematocrit. Finally, we decided to migrate the plasma clearance of ioxol from plasma analysis to DBS volumetric method, and we had to validate the method to be used in clinical practice under the European Medicine Agency, and the method fulfilled all the criteria. The DBS method has several advantages with respect to the standard procedure that is plasma analysis. Regarding the sampling, we use a painless finger prick, which increases the patient comfort. So we don't use a venous puncture. Regarding the volume of blood, for DBS we use a very reduced amount of blood. Then the DBS method can be performed in healthy centers, so we don't have to go to a hospital. The DBS, one of the main characteristics of the DBS sample is stability. So the stability for DBS of the ioxol in DBS samples is at least 6 months at room temperature, but for sure it's for years. So we don't have to use a freezer to conserve the samples, which reduces the cost for clinical studies between centers and so on. And also, the DBS samples can be sent by regular mail. So we don't need a special mail using dry ice or special containers. So the cost is very reduced. We use less phlebotomy material, and we don't have to aliquot and centrifuging the samples. And finally, there is not a biohazard in DBS samples because the dry blood inactivates viruses or bacteria, which increases the safety of the laboratory staff. These are two photographs just to see the comparison of the phlebotomy material that we have to use for plasma analysis and for DBS testing. Of course, like every method, DBS have limitations. We have to know the hematocrit level of the patients to correct the concentration of the ioxol from total blood to plasma. Anyway, the hematocrit analysis is a very well standardized procedure in any lab. And incomplete filling or air bubbles inside the capillary may limit the results, because it is very important to completely fill the capillary pipette with blood. This slide shows the way to correct and incorrectly take the samples. In panel A, we see the correct way to fill the capillary pipette with 10 microliters. In panel B, we can observe incomplete filling of the capillary. This invalidates the sample. And in panel C and D, we can observe bubbles inside the capillary. Just to let you know an historical perspective of the renal function laboratory led by Dr. Stamporini. In 2012, we cross-validate the laboratory against the Mario Negri Institute, led by Dr. Flavio Gaspari in Bergamo, Italy. 1 year later, or 6 months later, we performed the first GFR measurement using plasma analysis. In 2017, we migrate from plasma analysis to DBS method after validate the volumetric DBS method under the European Medicine Agency criteria. And up to now, the renal function laboratory have performed about 3,600 procedures in more than 2,000 patients in 8 years approximately. And the laboratory collaborates with 10 national and international centers. This is a slide showing a representation of the percentage of clinical conditions that the renal function laboratory have performed in these years. 60% of the cases were renal transplant patients. 16 of 16, pardon. Sorry. 16% pre-dialysis condition. 9% living kidney donors, 5% polycystic kidney disease and children, and then 24% of the cases are subjects in whom 24-hour creatinine clearance disagree with the formulas of estimations. Then the laboratory collaborates with clinical services in research studies at the Hospital Universitario de Canarias in Tenerife, evaluating the error of formulas in cirrhosis, liver transplantation, diabetes, cardiology, and oncology, among others. In conclusion, we can say that the DBS method is the DBS method to measure GFR or renal function is simple, reliable, and feasible. So there is no reason not to do it. And DBS may help to disseminate renal function measurement in clinical practice and research. Finally, just to show you the website of the renal function laboratory, and you are invited to visit it when you want. And there we explain it all the concerning to the measurement of renal function using DBS method and the plasma clearance of ioxol. And then during the coffee break, we will have a workshop where we can explain you, if you are interested, all the concerning this method. Thank you so much for your attention. If you have questions.
Thank you very much, Sergio. Any questions from the floor? There's one and one there. I go to.
This, and I think it's really something that could improve the quality of measurements in many patients and in many studies as well. So I may have missed it, but the requirements in the lab that are when you're receiving the dried blood spots, what do you need in terms of technical knowledge? Is it something that's very difficult to set up, or is it just standard laboratory?
When we receive the samples, we receive the samples by regular mail, and we store at room temperature, and we take these samples to the lab, punch off the spots, and that's all. It's very simple.
Perhaps you need just chromatographic analysis, just an HPLC. It's standard. It's irregular in many places.
HPLC is a standard technique in biochemistry. It's very simple.
Thank you very much, Sergio, for your presentation. My question is, we have a problem with the clinical practice with the living kidney donors. What are your opinion that use this measure in this kind of patients? What do you think?
Yes, we published an study where we observed that 1 out of 10 patients or living kidney donors could have donated based on estimated GFR when real GFR decline, the GFR was below the cutoff. So I think it is an important point because 10% of the living kidney donors are donating under the cutoff. So it's
I have a question. This method is now simplified regarding how to collect material from the patient that you have given a dose of iohexol. Do you see any improvement in the way you provide iohexol to the patient? Because you still, to do this test, you still need to give an IV injection of iohexol.
Mm-hmm.
So you still need to have a venous puncture, and the patient still needs to have this performed by a health professional. Do you see any advances that you could actually provide the iohexol in a more simplified way also, so that it will be a simplified way of iohexol providing and simplified DBS?
Now we are trying to short, in collaboration with the University of Oslo, we are trying to short the procedure from 8 hours for patients with estimated GFR less than 30 milliliters per minute, from 8 hours to 5. So this is an important point, and from 4 hours to 3 for patients with very conserved renal function. And I think that the way to administrate the iohexol has to be intravenously, this is mandatory. Because you have to be sure that all the dose goes immediately to the blood.
Yeah, well, thank you. That was actually part of my question as well. How do you administer it? And it is IV, you can't do it intramuscular, for instance, or oral, it has to be IV. And how long does it take? I mean, is it a standard peripheral venous access and then an infusion? And can the iohexol be reused, if you like? Can you give it on, say, day 0 and then measure it at day 7 and 14, or is it only good for one assessment?
Which is the question? Sorry.
Well, the first was, could you speak precisely to the procedure? How do you? Is it an IV infusion of the?
This is mandatory.
Yes, and how long does that take approximately? Half an hour to
1
10
minute.
minutes? 1 minute. Okay.
1 minute. So it's a bolus.
Yeah. Okay. And whether you could reuse it. So can you give one bolus and then measure the DBS many times afterwards, or only for one measurement per bolus? Yes. Okay. Yeah. Thank you.
Thank you. Regarding your point, there have been attempts to inject subcutaneous iotalamate, but the absorption is erratic. So you cannot rely on subcutaneous, for example. With iotalamate, I don't know if there has been tested with iohexol, but with iotalamate, we are not sure the speed of the absorption. So we have a problem with that. And I just wanted to make a comment that this method helped us tremendously to implement this in clinical practice, because there are so many conditions in which, for example, one formula gives 45 and then the other formula gives 65, and urine, 24-hour urine gives 35. And there are so many clinical conditions in which cirrhotic patients, renal transplantation, CKD, in which we spend a lot of money for many treatments and we don't spend money in an appropriate method to evaluate renal function, which is a parameter associated to worse outcomes.